Thank you so much, Georgette, for sharing your story and for offering, the one-to-one support over the phone. It really is such an impactful volunteer role you do, and we here, Mary Lou and I, are so blessed to get to hear those thank yous on the other end of the phone and really see the impact you make. So I hope it really does make a difference. Okay, and now our first formal presentation for the evening. Dr. Ardalan Ahmad is a urologic oncologist and assistant professor of urology at the University of Manitoba. Following his residency, he completed a urology oncology fellowship at the Princess Margaret Cancer Centre in Toronto. His research centers on outcomes of genitourinary malignancies. He leverages large administrative databases to drive insights. Clinically, his interests include urologic oncology and multidisciplinary oncology care, with a special focus on focal therapy for prostate cancer and advanced robotic surgical techniques. He is the consulting editor for European Urology, associate editor for BMC Urology, and the Focal Therapy Society membership chair. Dr. Ahmad, we're so thankful that you're here tonight.
Hi, everyone. Thank you for coming and for the invitation to join you tonight. Thank you for sharing your story. That's really impressive. I will be talking about non-muscle invasive bladder cancer, and there's a lot of slides, so I'll try to go a little bit faster, but if I'm going too fast, please let me know. So I have no disclosure for this talk, and I will be reviewing what is the epidemiology of bladder cancer, how does it present, what are the risk factors, how is it staged, what are the types of bladder cancer, and later on I'll focus on what treatments we've been using so far and what is in the pipeline coming out hopefully in the next few years. So bladder cancer is the 5th most common cancer in Canada. Unfortunately, it affects men significantly higher than women. And in this past year, or this year that we are in, about 12,000 Canadians are diagnosed with bladder cancer, and about 2,000 will die of the disease. It's a disease of the elderly, so age of diagnosis is usually about 73 years of age, but it can be seen at any age, including people who are young at 18 years of age. I told you that men are more likely to be diagnosed with bladder cancer, and this is because of genetic differences between men and women, exposure to sex hormones, but also the fact that men are more likely to be smokers. However, unfortunately, women present at higher stage, and that's because of multiple factors. The biology of the tumor is a bit different. Again, environmental exposures are different between men and women. But more importantly, it's very likely that most women with blood in the urine, which we call hematuria, are getting treated for UTIs for a few months before they are referred for a further evaluation by a specialist. In fact, when they look at the public data available in the States, the average time for referral for a man for gross hematuria is about 4 weeks, but for a woman it can be as long as 90 days. And we know that delaying diagnosis is usually associated with worse outcomes. What is the presentation? So I've already kind of mentioned that the most common presentation is blood in the urine. It can be visible blood, which we call it gross hematuria, or microscopic, which is not visible to naked eye. Obviously, the more the blood, the higher chances that there is something going on. So that's the number of 20% for gross hematuria. We find some form of malignancy, and about 2 to 5% for microscopic hematuria. But there are other symptoms suggestive of bladder cancer as well. So if someone presents with frequency of urination, urgency to pee, and waking up too much to pee at nighttime, and they don't respond well to our basic medical treatments, or they have associated blood in the urine, we always further investigate them to make sure they don't have bladder cancer. How about risk factors? So the most common or the most important risk factor is smoking. In fact, the association between smoking and bladder cancer is much stronger when you compare it to association between lung cancer and smoking. People who are smokers are 2 to 3 times higher at high risk of being diagnosed with bladder cancer. If someone stops smoking, over time the risk decreases, but it never goes down to levels that you see with non-smokers. Importantly, if somebody is diagnosed with bladder cancer, we emphasize that quitting smoking actually helps prevent recurrence of disease. So if patient is bladder cancer patient, they keep smoking, chances are they're going to have recurrence of disease or progression of disease. What about other factors? So it could be genetic factors or hereditary factors, problems with DNA repair. This is Lynch syndrome. There's association of few other malignancies, including kidney cancer and bladder cancer. So that is a possibility. Obesity, higher body weight means that people are in a hyperinsulinemic situation or condition, meaning the body it produces a lot of insulin, and insulin resistance causes chronic inflammation, and that's a risk factor for bladder cancer. Occupation, so people who are exposed to tobacco of any sort, rubber, dye, hairdressers, nurses, and doctors are also at risk of bladder cancer because of their exposures they have. However, there are also medical conditions such as diabetes, and medications we use for diabetes, such as pioglitazone, or prior radiation therapy or chemotherapy. People who have spinal cord injury and have chronic inflammation, infection in the bladder because of catheters, or people who get a lot of infections in the bladder, they are at risk of bladder cancer. Good news or bad news is that there is no association between what you eat and bladder cancer. So there is no diet that prevents bladder cancer or helps you not have recurrence in the future. What about assessment workup? You probably have heard that there are 3 tests that needs to be done for someone who we suspect they have bladder cancer. One is a cross-sectional imaging called CT scan or MRI. This is to mainly assess the kidneys and the tubes between the kidneys and the bladder called ureter. Unfortunately, CT scan is not sensitive enough to pick up bladder cancer unless it's a very big tumor in the bladder. So for that reason, we have to directly look inside the bladder, called cystoscopy, essentially a catheter with a camera at the end. Outpatient procedure under local, we place the catheter per urethra into the bladder, look around, and if we see tumor, we kind of describe it, how many are there, how do they look like, and basically describe it in our note. Finally, we send urine cytology because we want to know if there's cancer cells floating in the urine or not. There are other markers available in the market, but clinically they are not as specific as urine cytology, so they have never really been used too often in our clinical practice. One of the new developments, at least in the past decade or so, is blue light cystoscopy. This is a newer technology. It's essentially an hour before cystoscopy, we place either HAL or ALA in the bladder and wait. These molecules are picked up by the cancer cells more than the normal cells, and then once we put this cystoscope inside and shine blue light, you can see the cancer turning red or orange. If you look at the picture, the right-hand side, on the right-hand side, there may be like 4 or 5 tumors that you can see, but once you use the blue light cystoscopy, there are about 6 to 7 tumors. This technology is widely used in the States and some places in Canada. And the big thing about it is it's when you see things better, you're going to resect them better and remove the tumor, so the chance of recurrence decreases, at least in the short term, the first 3 to 12 months after the procedure called TURBT. Another technology available to us is narrowband imaging. This is basically this light source illuminates 2 different wavelengths of light, and we can see the tumor and also blood vessels in the bladder much better. Also been shown that the recurrences decreases initially, but in the long term, it hasn't been panned out as we expected. How about what type of bladder tumors we have and how do we stage it? So when we looked inside the bladder, as some of you were watching what we do during cystoscopy, this is most of the time what we see. Cauliflower lesion, usually small, and 1 or 2 of them. And but we also see nodularities, like a very solid big mass, or we see carpets of redness called carcinoma in situ. Overall, majority of bladder cancers are called transitional cell carcinoma, or more recently we call them urothelial carcinoma. But we can have other types of cancer in the bladder as well, including a small cell or neuroendocrine, squamous cell adenocarcinoma, microvariant, and plasmacytoid. Importantly, these variants of bladder cancer are usually more aggressive, meaning that if patients are having surgery, we find out that at the time of surgery, the tumor is more aggressive, higher stage. So that's why in most instances we offer radical surgery to these patients rather than treatments in the bladder. So a bladder has basically it's a thick wall, especially in men, and there are at least 5 layers. There is an inner layer called mucosa, and there is a submucosa or lamina propria, which is basically this thin layer, and then a thick muscle bundle, fat, and then lining of the bowel basically outside here. So when we want to know what bladder cancer we're dealing with, beside the features at the level of the cell, we also want to know which layer of this wall of the bladder the tumor has spread to. Thankfully, most bladder tumors are actually just sitting on the surface and not reaching to the muscle. And that's a really important fact that we have to differentiate between the non-muscle invasive group and muscle invasive group, because the treatments are drastically different. For non-muscle invasive group, we have either TA, which means that the tumor is just on the surface, it hasn't really started growing, or T1, that it means the tumor started growing into the submucosal layer. We also have carcinoma in site 2, which is basically a flat lining of the cells. Although it's on the surface, these are highly aggressive and actually a risk factor for disease being bad and being a bad actor. So when you look at the distribution of the cancers in the bladder, as I said, 70% are non-muscle invasive. However, about 20 to 30% are considered more muscle invasive. Good or bad thing about these non-muscle invasive disease is that they are coming back quite frequently. So it's not one shot and one stop that you basically go and you're done with. Unfortunately, these tend to come back up to 60, 70% of the time. But importantly, they are also at risk of progression. So some of these cancers can progress, meaning they can become T2 or T3, or even start metastasizing up to 50% of the time. So we come back to talk about that in a little bit. So we used basically what the pathologist gives us about what type of tumor it is, what is the stage that we just talked about, how many tumors are there, what is the grade, and certain associated features to decide what risk category of bladder cancer is basically sitting in. The low risk ones are the ones that are less likely to progress. In fact, risk of progression is usually about 2 to 3%, but they tend to come back quite frequently. As we get a bit more aggressive, people who have maybe a little bit of high-grade disease or a little bit of tumor growing into the wall, but not all the way through, these are intermediate risk. But the high-risk group is the one that we are most concerned about. These are the patients who, besides having the tumor coming back, they're at risk of progression. As I said, it can be as high as 50%. So basically what I just talked about, the treatment we choose for non-muscle invasive bladder cancer is based on the risk of the bladder cancer. That's why we need to know all those information. And we talk about these information with the patient before deciding what to do next. How about treatments? So treatment starts with TURBT. TURBT, or transurethral resection bladder tumor, is a procedure done under anesthesia. We look with the telescope inside the bladder, use these electrocautery loops and resect the tumor. The goal is to remove all the tumor and go deep enough so we know how deep the tumor is growing once the pathologist looked at it under the microscope. And there are certain conditions or situations that we have to go back within a short period of time and re-resect the base of the tumor, because either this resection was not complete or certain features on pathology suggest that there may be tumor even further down in the wall of the bladder. So that's why we suggest repeat TURBT to some patients, and that's to make sure that we're not missing the risk, a high-risk disease, which can happen up to 50% of the time. So what are the treatment options for low-risk bladder cancer? So just to memorize or just review, low-risk bladder cancer is TA, meaning it's just on the surface. It's usually low or high grade. It's usually low grade, single or maybe a couple of tumors, but not too many of them. As you can see, risk of recurrence is about 70%, but risk of progression is very low. For these tumors, we can just do the TURBT and kind of keep watching the bladder with cystoscopies every so often, usually at 3 months and 12 months, and then once a year for the rest of life. One of the options we have is, in addition to TURBT, because once we are operating on a patient, when we touch these tumors, the cancer cells start flowing in the urine, And these cancer cells can get stuck to other parts of the bladder and cause new tumors showing up later on. So we give a little bit of chemotherapy in the bladder just immediately after the procedure for about an hour or two. And that has been shown to decrease risk of recurrence by about 30%. However, this type of treatment, meaning chemotherapy inside the bladder, does not prevent the tumor from getting worse. So that's in brief what we offer to our patients with low risk bladder cancer. Interestingly, we also have studies showing just washing the bladder for about 20 hours with normal saline, which is salt water, prevents tumor from coming back. So sometimes we admit the patient overnight, run the fluid, wash the bladder, and then send them home the next day. How about intermediate risk bladder cancer? These are basically tumors that are a little bit more aggressive or more growing into the deeper in the wall. These tumors usually have higher risk of similar risk of recurrence, but higher risk of progression. And the treatments are essentially immunotherapy or chemotherapy. And the immunotherapy that you all know about is BCG. There are other immunotherapies that we're going to talk about later on as well. Again, as I mentioned earlier, chemotherapy is good at preventing tumor from coming back. Excuse me. But it doesn't prevent progression. So high-risk bladder cancer is basically either carcinoma in situ. I mentioned that these are on the surface, but these are highly aggressive. These are at risk of progression up to 80% of the time. So if left untreated, patient with cancer of the bladder, which is carcinoma in situ, 80% chance in the next couple of years they have muscle invasive or worse disease. Chance of recurrence is also about 60%. T1 is when the tumor actually starts growing to this submucosal layer, and most of these are high grade. Again, risk of recurrence is about 50%, and risk of progression, especially if they're associated with carcinoma in situ, can be as high as 80%. What are the treatment options for high-risk disease? Again, immunotherapy with BCG or interferon, or combination of the two. Early cystectomy in certain patients is actually standard of care. These are the patients who do not respond to BCG treatments or have certain high-risk features, meaning that there's a lot of tumor inside this second layer. The tumor is almost touching the muscle of the bladder, or there is carcinoma in situ or invasion of blood vessels in the specimen, or variant histology that we talked about. Also, we can use intravesical chemotherapy, which we've talked about in a little bit, combination therapies, and there are new treatments available, including gene therapy, immunotherapy, and immunotherapy inside the bladder. So what is BCG? BCG is essentially a vaccine that is used in the third world where the tuberculosis is quite common, to prevent tuberculosis. So a lot of countries that have a significant incidence of tuberculosis, as kids are born, they are immunized with BCG. In early 1970s, we noticed that people who had BCG vaccination and have bladder tumors, they tend to have less recurrence and less progression of disease. That was the basis to use BCG in the bladder. It's a different combination, but we use it in the bladder now to help us eradicate the tumor and prevent progression. So that's the main thing about BCG. It prevents recurrence, it prevents progression. So it's a live mycobacterium, so it's a live bacteria. That's why when we review this option, patients will always say there's a chance you will be diagnosed with tuberculosis. It's not high, but it is possible. What it does, as soon as it gets into the bladder, it kind of gets connected to this lining of the bladder and creates a very intense immune response using what we call T helper cells. And basically the immune system kind of flows into the wall of the bladder. As it comes to the wall of the bladder, anything that is not familiar to it, it will destroy it, include the urothelial cancer cells. So when we use the BCG, we see that up to 80% of the patients have complete response initially. And these responses can last up to 4 years, and in fact, in a period of 10 years, still a third of the patients do not have recurrence and they are not having any progression. So for decades, this was what we have. Essentially, late 1970s to about a decade ago, that's all we had, and that's all what we basically offered to the patients. But there are other medications, other treatments coming in that is challenging the BCG. The other indication to use the BCG is if for some reason we cannot remove the tumor in the bladder and there's some residual left, we can use the BCG to get rid of the tumor as well. We have many studies looking at basically BCG versus chemotherapy. Complete response rate with BCG in this study was about 70% compared to 50%, but importantly, disease progression was not changed with chemotherapy, but it was dropped down by about 60% with BCG. So it is really a good treatment, and the reason that we couldn't find anything better because nothing could give us the same outcomes.
Excuse me.
Yes.
I was a nurse, and when I went into training, we got BCG shots. Does that affect? I now have bladder cancer.
It's not remote history doesn't, but it was basically, as I said, there was a patient who had bladder cancer. They also got the BCG vaccine,
Yes.
and they come to realize that he's doing better than the rest of the patients. So that's why they figured that this might work. So how about how do we give BCG? So if you hear if your family members have already been treated, it's once a week treatments in the bladder. A catheter goes inside the bladder, and we give these injections for 6 weeks in a row. We wait about 4 or 5 weeks, take another look inside the bladder. If the tumor is gone, we will give the maintenance dose. And the important thing is, without maintenance, the outcomes are not as good. So it's really important to give the maintenance depending on the cancer risk, at least 1 year, sometimes up to 3 years. And with this regimen, we see the outcomes we just talked about. So recurrence decreased by 80% and progression decreased by about 60%. However, when we look at the long-term data from the SWOG trial, we see just about less than 20% of the patients are able to tolerate a 3-year period of toxicity associated with BCG because it has a cumulative effect. So most people tend to do very well with the first and second one, and then as you get more and more BCG, it's harder for you to tolerate it. It is important to also mention that we don't say somebody is not a candidate for BCG anymore if they fail the first treatment course. So if they got 6 weeks, there's still a bit of tumor, or the tumor has not completely gone away, we can always try another induction dose because it's still about 30% chance that after the second induction dose, they have a good response and the tumor goes away. How about, the other thing is some people will ask me, so well, I had two courses, it did a little bit, but still I had tumor. After the second dose, it's just really not a good idea to keep giving BCG or any other type of treatment because each time we give more BCG, we're putting patient at risk of progression by about 10%, meaning that the cancer can start growing into the lymph nodes or go somewhere else in the body. So if it doesn't work after second time induction, so 2 6 weeks courses of induction BCG, we usually suggest we should find some other alternative. Interferon is also a stimulant of the immune system. It's not very specific. That's why it doesn't give the nice responses we see with the BCG. But we can combine interferon with BCG and see similar outcomes as far as a response to treatment. However, this is a really good combination when the patient cannot tolerate the full dose BCG. So we add the interferon and decrease the dose of BCG, which is very irritating to some, to help them be continuing on their treatment with BCG. So that's a good, nice combination. Sometimes we can still use it.
You said that only 16% of patients can tolerate the after 3-year course due to toxicity. So how does that toxicity present itself?
So most common toxicity is what we call irritated voiding symptoms. So the urgency, constant need to pee, bladder pain, pain with urination, and that becomes really bothersome to patients. Also, some patients get pretty bad infections, including normal UTIs that we get that gets very severe, but also tuberculosis is a big thing. So if somebody is diagnosed with tuberculosis, they are no longer supposed to get BCG treatments. How about, intravesical treatments? As I mentioned earlier, these are not as effective as BCG or combination BCG and interferon. There are different ways to give the chemotherapy. One of the ways that we use is hyperthermic therapies. Essentially, we put mitomycin C, which is a chemotherapy agent, in the bladder and somehow warm up the bladder, either with electrodes outside or electrodes inside. And nowadays, we also have the option of warming up the medication, put it in circulation that keeps it about 42 degrees centigrade. And once the medication is heated up, it has a better delivery to the wall of the bladder and decreased risk of recurrence. However, when we combined chemotherapy with BCG, we didn't see a really good outcome or additive outcome by adding chemotherapy to BCG. So nowadays, this combination is out of the picture. This is a term that you might have heard or hear if you are treated with BCG, it's BCG failure. It means that for some reason, the patient cannot get any more BCG. This reason could be that they cannot tolerate it. It's just they cannot hold the medication. It's too many side effects, so they stop taking it. But most of the time, we deal with refractory or BCG refractory disease or BCG resistant. We use these terms to decide when we should proceed to the next step. These are a little bit challenging because everybody uses different definitions. So the FDA basically used a very standard definition, saying if somebody gets 6 cycles of induction plus 2 out of 3 maintenance, and they still have a tumor in the bladder, they are BCG unresponsive. So nowadays, a lot of studies that are coming out basically use that definition. So it's a standard definition that has been used for the past 5 to 6 years. What are the treatments for patients who are BCG refractory? The standard of care as of now is to remove the bladder. So if BCG is not working for a patient, the bladder needs to come out, because as I said, keep giving the same medication or switching to other treatments such as chemotherapy in the bladder just puts the patient at risk of worsening disease. But if the patient is not fit to have surgery or they're unwilling, then we can use the chemotherapy, we can use photodynamic therapy, even radiation therapy or combination of radiation therapy and systemic chemotherapy, which we will talk about in a bit. So BCG refractory disease, we can give single agent chemotherapy or combinations. The combinations are more popular because of the outcomes being more positive and more prominent. So we can combine gemcitabine with mitomycin or docetaxel with mitomycin, and basically each of these is going to be in the bladder for about an hour. And once the 6 weeks course is done, you continue at least 12 to 24 months of maintenance once a month. And in BCG refractory disease, it decreased the recurrence rate by about 40%. The more prominent combination that basically there's a lot of hype around it, and there's a big study right now going on, is combining gemcitabine and docetaxel. Why this is very much under attention is because it has a very low side effect profile and extremely good outcomes in 2 years. So induction dose and 2 years of maintenance, about 35% patients are disease-free at 2 years. So this is pretty much unheard of. If you keep giving BCG after the second cycle, maybe 5% to 10% improvement in the outcomes, but this is about 34, 35%. What is photodynamic therapy? If you remember, I talked about these 2 molecules earlier on at the time of blue light cystoscopy. So these molecules are placed in the bladder, and we add some form of a medication to them. Then we basically place a scope that shines this green light laser inside. And as the laser hits these molecules, it activates the medication, and the medication causes free radicals formation in the bladder. Free radicals of oxygen are highly toxic, and they are accumulating in the cancer cells. So basically using those free radicals, the cancer cells are being hit and they die. So the response rate is about 50 to 60%. However, the main problem with it is lots of pain with urination, lots of irritation, and also the bladder can get scarred and become very small. So that non-functional bladder is a big thing. That's why it hasn't really picked up much. How about novel treatments? if you're following any type of cancer treatment, or cancer treatment news, you come up with this term called immune checkpoint inhibitors or immunotherapy. One of the main medications that is available in Canada and States is pembrolizumab. This is an immune checkpoint inhibitor that given in the form of systemic therapy, meaning in the veins, in patients who are unresponsive to BCG and they have carcinoma in situ. The carcinoma in situ can be just the only diagnosis or in association with papillary lesion, and at 3-month complete response rate, about 40% response can last up to a year and a half. And when you have a papillary lesions, the outcomes are just a little better. But this is one of the main treatment options for BCG unresponsive carcinoma in situ of the bladder that the medical oncologists provide to our patients. How about gene-based therapies? These are basically treatments that has been reported in the past 6 to 7 months. So the idea is that we use a part of the human genome added to a virus that is a vector for that genome, and we basically place that in the cancer cells. And once this gene starts getting activated, it produces such a strong immune response that about 53% of the patients don't have any tumors at 3 months, and about 20% no tumors at 12 months. Again, as we talked about in the previous slides, papillary tumors tend to have better response of up to 70% at 3 months, and 60% of the patients are free of tumor even a year after the treatment. The second gene-based therapy is CG0070. The same idea, it basically adenovirus that goes inside the cell. It targets the cell that has a specific mutation. This is a very common mutation in high-risk disease. And once it's inside, it basically causes the tumor cells to die. Complete response rate is about 75%. That's extremely well, even I would say better than BCG treatment. And remember, these are patients who BCG doesn't work for them anymore. And normally you would have said you have to have your bladder out. And these responses can last more than 6 months. Importantly, no major side effects. So minor side effects are common, but no major side effects. Another trial looking at a combination of basically pembrolizumab, which is an immunotherapy agent, with CG0070, small number of patients, 85% of patients don't have any tumors, and the treatment response lasts almost about a year. Again, not much of a side effect. This is the fresh out of the conferences. A few weeks ago, there was a conference in Europe, medical oncology conference, and they just presented their results. TAR system is essentially this kind of Pringle-shaped device that we put through the cystoscopy inside the bladder. It is filled with gemcitabine, which is a chemotherapy agent, and over time it releases the medication. So there's constant exposure of the whole bladder to this chemotherapy agent. This trial had 3 arms, but the main arm that everybody is so excited about is the TAR 200 only. In these patients, about 85% had complete response, and the response lasted at least almost 10 months. Some patients had major side effects, but generally well tolerated. We as urologists are very excited about this because we are very familiar with how gemcitabine works, and we can handle the side effects very easy. And we don't need to have a medical oncologist help us give this medication to the patients. Finally, this is another intravesical treatment known as N-803. This is also a very new, basically, study coming out, phase 2 trial. Interleukin-15 is a part of the immune system, so it basically an agonist of the interleukin-15. It causes significant immune responses to the bladder for someone who's not responding to BCG. Similar response rate of about 70%, but it prevents need for cystectomy in almost 90% of the patient, even up to 2 years after their treatment, and 100% of the patients are still alive after they were treated with this treatment. So that being said, this is my last slide for BCG failures. It used to be that we basically define that the patient is no longer responding to BCG and say, either go have your bladder out or there are other options that don't really work well, but because you're not a candidate, we don't have much to offer you. So if you have a BCG failure patient, if you have a trial, we try to include the patient in that trial, but depending on their initial biology, we have at least 4, maybe 5 different options. And these are the options we talked about: combination of chemotherapy, intravesical, basically treatments, combination of intravesical treatment, BCG, pembrolizumab, which is an immunotherapy, and on this side we have the hyperthermia treatments with chemotherapy as well. So a lot is happening in bladder cancer field. In fact, if you look at the number of studies and trials going on, it's about 1,000 studies right now. This compares to about 300 for prostate cancer and about 150 in kidney cancer. So it used to be that as urologists, we see a lot of focus on prostate cancer, but now bladder cancer has picked up. So a lot of things are changing with bladder cancer, and we will have much better treatments in the next 5 to 10 years. That being said, thanks again for this opportunity, and I'm happy to take any questions.
If you had a patient who had a successful TURBT on a non-muscle invasive tumor, and given the fact that they have a high risk of recurrence, would you recommend it within their means to have regular blue light cystoscopies if that's something that they are able to do?
So blue light cystoscopies, if it's available, yes. If they are at high risk of recurrence, we'll always discuss the option that just TRBT is probably not going to work. As I mentioned to you, up to 80% will get worse, maybe 60–70% they will come back. So that's why we always talk about BCG. If BCG is not an option, we talk about chemotherapy. And the blue light cystoscopy is good for initial diagnosis surveillance. Most places in Canada use it when patient doesn't have an obvious tumor in the bladder, but the cytology, which is the urine test, is constantly positive. So most places use it in that setting specifically because it's a technology that's not widely available. We need financial support to buy the instrument. It's about 60 grand, but hospitals have to pay out of pocket. So it's not widely available.
Is the TAR 200 or the N803 available?
So TAR is now with FDA to get approved, and then Health Canada has to approve it. So it will be at least a year and a half before we have TAR in our system, if it's approved by Health Canada.
Same with the N803.
Those are a little bit further out.
Is BCG considered a failure if you go through 2 years with no problems, but in the 3rd year you can't tolerate it? Or
So as I said, we usually, so there's early and late, basically BCG failures. So what you're describing is considered late BCG failure. We won't say that you need treatment if there's no tumor. We always say, okay, you've got 2 years, there's no tumor, just keep an eye on you. Do cystoscopies, if you need to do CT scans, we do CT scans. But if after 2 years you still have high-grade tumor, then it means the BCG didn't work. So in that case, we have to talk about alternatives.
is it possible for low grade to convert to high grade?
It is possible, but usually the problem is in the initial resection, the high-grade part was a small component, wasn't picked up. So because when we look at genetic lineage of these 2 type of tumor, they're completely different. When you compare them, as I said, there are certain genes that are very specific to high-grade disease, certain genes that are very specific to low-risk disease. And usually they don't cross-match each other, or they don't go across. So it is very unlikely, but it has happened. Most of the time it's because we didn't have the right diagnosis to begin with.
Thank you so much, Dr. Ahmad. That was great. I really appreciate your time today.